Colleagues, ladies and gentlemen, good afternoon.
Good afternoon.
I appreciate the toil that the previous presenters have put in to make it a lot simpler for me to come and simply solve or make things a lot simpler as pathology. So I will quickly race you through the basic pathology, the pathogenesis, then we will go to the diagnosis. I will forgive you that I will not present the histological appearance, but I will take you through the histological patterns. So, and I'm optimistic that by the time we leave, then we can tie up all the presentations and make a good, wholesome picture, because we've heard from the clinician, we've heard from the radiologist, and therefore the pathology becomes a lot simpler thereafter. But what is interstitial lung disease? I thought we should be able to go through the other aliases. In several texts you will find others call it the diffuse interstitial lung disease, fibrotic interstitial lung disease, pulmonary fibrosis. All the older texts refer to the pneumoconiosis. And like William earlier said, now I'm learning that there are over 200, but it's a broad group of several hundred inflammatory lung disorders. If we go ahead, we can organize it again under several subgroups, depending on whether the cause is known or there is unknown association, or we do not know any cause at all. And this is just a summary of what the others have presented to us, so I will not dwell a lot on that. You can see what falls under the known and what is falling under the unknown. Several differentials to consider. Primarily, interstitial lung disease, of course, is disease of the interstitium. But you have to know, as a pathologist, where the interstitium is, so that then you can be able to read your sections correctly. Else you will be reading elsewhere if you do not know. So the interstitium is nothing but the area between the alveolar endothelia and the capillary endothelial basement membrane. But we have to also take note that the term interstitial lung disease is a misnomer, because the disease has been known to also involve structures outside the interstitium. The alveoli, we heard about the DAD, the diffuse alveolar damage. The alveoli are not in the interstitium. It can also affect the bronchioles. And it has also been known to go and eventually affect the pleura. So it is a misnomer. But you need to be able to appreciate this to revise your anatomy and basic histology. And there we see the pictorial depiction of the interstitium. The bottom slide is a section of the normal lung, and that is ideally what the normal section of lung should appear. Nice and thin, but once you get that thickened, then you know you are dealing with disease in the interstitium, because our interstitium should always remain thin and nice. And nice is something infiltrating. And we know what always swims in the interstitium are the several cells, but chiefly the macrophages, those marabou stalks. So the pathogenesis, the pathology of interstitial lung disease is nothing but always inflammatory disease. And so you have an exposure to an agent. Of course, if you remember your general pathology, once you have an evoking agent, what you will get will be a cellular response within that interstitium. And what follows when we inflame, we eventually have to heal. But when you get repeated exposure to the agent and therefore repeated cellular response and several attempts to heal, the body says, I will heal with fibrosis. Because remember, we have the macrophages, and the macrophages are squirting lots of several other cytokines that are attracting other cells, the fibroblasts. And some of those cytokines are also fibroblastic stimulating. So you end up with permanent damage within the interstitium. And we should appreciate from what we know that there are several things that will injure the lung, as other speakers have already told us. A whole range of ways to injure the lung. So, but we have to also consider the acuteness or the acuity of the injury. The duration we had from the history. One had 7 years, another had several other years. Because when we consider this, then we can know what to expect as pathologists. When you are presenting the acute interstitial pneumonia, when you say acute, as a pathologist, I know what kind of cells I will expect, unless it is an acute or chronic. So if it is acute, I quickly go to think about the neutrophils. And then I will not expect to see any fibrosis because it is an acute process. But because we have continuing injury and imperfect repair, because you always have injury but never time to heal properly, so you will get progressive damage, and eventually this damage takes over where the normal existed. So that is how the disease keeps progressing. Is there a role for pathology in the diagnosis of interstitial lung disease? Yes, but we have to be cautious. The statements are there. A lung biopsy is not required in all patients with interstitial lung disease. However, it is not frequently possible to reach a definitive diagnosis or even to state the disease without the examination of the lung tissue. Not the naked eye examination, but the histological examination of the lung disease. And we've heard that the differential, if you list the differentials, I think they can stretch from 1 degree up to here. So we have to be very meticulous in the way we look at this so that we do not have a whole textbook of diagnosis for the patient, else you will not know what to treat. And like William earlier said, you may not just go in to take a biopsy. But what are the indications for a biopsy? When we want to assess disease activity, when we want to identify a more treatable condition, if we want to exclude a neoplasm or infection, because then we will know what course to take. When we want to establish a more definitive diagnosis before we start on treatment that may be a little dangerous. Or when we want to provide a more specific diagnosis, particularly in patients that have a very atypical or progressive pattern, or those who may present with nearly normal X-rays, or those that may have atypical X-rays that are not fitting in the picture of interstitial lung disease. So the types of biopsies, if you've gone in with your bronchoscope, you have an opportunity to attach your gadget at the end and then do a transbronchial biopsy. But this has a limitation, because imagine the whole lung, you are only pinching for me a few centimeters. And remember, disease is not organized in such a way that what you see in the apices will be the same that you see in the hilar or in the bottom, in the bases. So you are only somehow blindly pinching something small for me. So when I know, I may give you a very unexpected answer. So that is the limitation for the transbronchial. There is the video-assisted thoracoscopic biopsy, probably more targeted, but there is also room for an open biopsy. Is there a role for bronchoalveolar lavage? Very limited. Very limited. I wouldn't put it on my list. So contraindications for taking a biopsy: if a person has severe cardiovascular disease, if there is radiologic evidence of diffuse end-stage disease, anechomy, and if there is severe pulmonary dysfunction, do not attempt to biopsy, or biopsy with caution. So, in the face of the complex world of interstitial lung disease, the pathologist is also baffled. Remember, pathologists are not magicians. That's what usually people think, that you just send a biopsy and then the pathologist tells you what it is. So if for a relevant and clinically useful histopathological diagnosis, we need the clinical information, the beautiful radiological information, so that we can tie those up into one suitcase and come up with a clinical, radiological, histopathological diagnosis. I alone cannot give you good diagnosis with it. So, like any other good diagnostic strategy, the first thing is the patient. And the clinicians presented so beautifully well. The patient was very clear to me as a pathologist. And when the radiologist came, it was not beautiful. So now for me, at this point when you send the biopsy, I will know. So in order to navigate this complex world, the pathologist will use a pattern-based approach, because as you've heard, there are many differentials, and unless you develop a very systematic way of how you approach your biopsy, you are going to get lost in that biopsy. You will not know what you are reading out, and therefore you will not be able to provide a clinically useful diagnosis. So in histopathology, we have the 6 basic patterns that will be giving us what differentials to consider, because we realize that the differentials will begin to fall in certain specific groups, therefore making the case more manageable to provide a good thought about the diagnosis. But remember that sometimes the disease is so mixed that in histo you may see 3 patterns in one specimen, but always take the dominant pattern. So pattern number 1, what we call an acute injury pattern. Pattern number 2 is the fibrosis pattern. 3 is the cellular infiltrates pattern. 4 is when you have a pattern that has airspace filling. 5 is when you have nodules. And 6 is when you have minimal change. You remember minimal change disease in the kidneys? It is also appearing in the lungs. But remember that sometimes the patterns also overlap. So if we go by the pattern number 1, acute injury, again, if I take you back to basic pathology, acute injury, it is not surprising that you will have edema, because edema is the acute response. So you will have interstitial edema. You may have intra-alveolar fibrin formation because you are having an inflammation there. And then your pneumocytes type 2 become reactive because you are destroying the type 1, and therefore the type 2 become reactive to be able to replace what is being destroyed. Sometimes you may have also hyaline membranes there. We are dealing with acute injury, so necrosis is not a surprising finding there. Hemorrhage, sometimes you will find eosinophils, but if you have had background disease and you are dealing with an acute phase, you may have also background fibrosis, because that depicts previous damage. And this is very typical in what we are seeing as acute clinical lung disease. Hence, the reason I stress telling us the acuteness of the disease, so that then I can also begin to factor in these thoughts once I'm looking at the slide for you. So the examples that fall under here are that, or the organizing pneumonias, or even the eosinophilic pneumonias, but depending on what I'm reading on the slide. The second category, fibrosis, speaks for itself. You are going to see dense deposition of collagen in the lung parenchyma, but it will be associated with remodeling and sometimes loss of the alveoli. Additionals, it may come with honeycombing. You may have uniform alveolar wall involvement, or you may have an airway that is being impinged on by fibrosis. I heard the radiologist talk about that. Or you may have stellate scars. And this is very typical in the UIP. Category or pattern 3 is when we talk about the cellular infiltrate. And here we will be seeing chronic inflammatory cells, which we all know, chiefly the lymphocytes and the plasma cells, and they are going through the tissue. Sometimes these chronic inflammatory cells may be associated with poorly forming granulomas, or even well-forming granulomas. And therefore the diseases to think about there are the LIP, the lymphocyte interstitial pneumonia, or the non-specific interstitial pneumonia. Those are the differentials under there. The other pattern where you have alveolar filling, of course, like they say, pathology is always just simple and logical. When I say alveolar filling, of course you are going to have alveolar filling with either cells or non-cellular material. So sometimes we see macrophages in there, you see neutrophils there, you see blood, eosinophilic material, or siderophages. Those are macrophages that have eaten up some stuff. Or sometimes you are seeing immature fibroblasts, and the differentials are underlined there. The book, although I was cautioned not to talk about the book, or the pulmonary alveoli proteinosis, which is PAP, or the desquamative interstitial pneumonia, because desquamation is taking place within the alveolar space. So we are having cellular debris falling into the alveolar space. So it is alveolar filling. That is how I read the slides. So the pattern associated with nodules, So once I see the nodules, I ask myself, are they well formed or poorly formed? Are they small or large? Am I seeing single nodules or numerous? And again, the nodules may be very typical of granulomas, or they may be nodules of lymphoid cells, or they may be nodules of atypical cells, because sometimes you may have something else there. Or they could be macrophages, or it could be a collection of dust, because once dust gets there, the reaction is for macrophages to come and try to scavenge on the dust. Or they could be the lung and cells. And the differentials there are the lung and cell histiocytosis or sarcoidosis, because it is typically granulomatous disease. The other pattern, which is the last pattern, is the minimal change, and this is what I fear most, because sometimes I'm not seeing anything significant, and I'm scared what to tell William. I don't know the diagnosis. So in this pattern, there is little pathology evident at my scanning magnification, because I'm looking at all these slides at scanning magnification, low power, times 5 or 4 or 10. But sometimes you may chance to see a little bit of constrictive bronchiolitis, or you may see some cysts around, or even some lymphatic or vesicular change. Because remember, I said that ILD is a misnomer, because it may also have involvement of the vessels and not only the interstitial. So sometimes when I'm not seeing a lot of change in the interstitial, the change may be around the vessels, and that falls under the minimal change disease. I beg to submit.